Sarita, I want to see you. I said I'm here with you. Dr. Rita
Okay,
is also here.
hello. Okay,
Yes.
okay. So we have 20 participants, but it seems that every screen is about 2 people or more. So
Yes.
great,
Yes.
very good.
Okay. Okay.
So good afternoon and good morning, everybody. We welcome everybody for this third meeting of these meetings, and Dr. Winty will not be able to join in the morning as she was called in for on-call, unexpected on-call. And that's why we switched her talk, and she will join us probably later. And we have a very busy session. I'm sure that attendance, Rita and Ashura, you will keep the attendance as needed. And I just want to welcome everybody. I was very happy to hear that after the previous meetings, you had a lot of discussion inside the units. I think this is much more than we ever think. It's very constructive and very good that you continue the discussion between yourselves and ask questions and even send to us, which was excellent. All the lectures that are going to happen today and happened before everything will be available online for further for you to see the lectures and even to go again through them and educate newer nurses who will come to the units. So at this point, if anybody has any specific thing to add to this opening remarks, we're all good to start. So our meeting today will be 4 topics. Actually, one will be on deterioration of an infant on CPAP, weaning from CPAP, low-cost intervention to prevent complications of prematurity, and feeding on CPAP. Weaning, feeding, deterioration, and complications of prematurity. So that's a lot. And let's start. Okay, so let me share my screen. I will try to go as slow as I can. Okay, so my first talk will summarize issues related to deterioration of an infant on CPAP. Now, I would start by saying that we suggest everybody to read through the manual. The manual, which has the basics of CPAP. We had the first meeting that Dr. Elon also talked to us about the principles of CPAP, and now we are going to discuss more. For this meeting, I suggest again to read through the manual, and the same for the upcoming meetings too. So this is a hospital where I used to work before I got to pension, and this is a place where Elon is going still every day in service, and where we all wait for you to welcome and stay with us whenever this will be possible. So let's land to a baby who is on CPAP and remind ourselves that this baby is probably in the special care room where we have the overheads, and the baby is on an overhead, has saturation monitor connected to his right hand, and has regular monitoring of his vital signs, has charting according to what we developed together, and all the equipment necessary for any acute or intervention or deterioration is ready in the room, like an oxygen cylinder, backup cylinder, an ambu bag, suction devices, and a set for draining of pneumothorax, whatever this is in your practice. Everything should be in the room and everybody should know where this equipment is. Now, we do not talk here about the indications for CPAP. We've discussed it in the first sessions, but I want to remind for us a hot topic, I would say, that CPAP is not very helpful in your setups for babies less than 1 kilo and less than 28 weeks gestational ages. In babies with severe burst asphyxia who are not breathing or moribund or severely damaged, and for babies who are not breathing. So what would be the sign that the baby in the setup that I just talked about is deteriorating? Either there is an increased oxygen requirement, it's an increased heart rate, increase in the respiratory score, which we are monitoring, the Down score, or the infant is restless and uncomfortable. The deterioration of the baby can be sudden, just like boom. It can be intermittent. The baby is desatting and coming back and desatting. And it can be slowly progressive, like in a certain direction, slowly increasing on the oxygen requirement, slowly increasing of the respiratory rate, and so on. The three different patterns are a little bit suggestive of the possible cause of the deterioration. How often we have babies deteriorating on CPAP? It's not really good enough literature to tell you what is known in these babies. We know that the literature says 5% of the babies have pneumothorax on CPAP. And when we document, as you see, the papers that you fill in for yourselves and for us, is actually we do ask the questions, why did you discontinue the CPAP, whether it was a deterioration or there was a technical problem or the baby was improving. So we can collect data and maybe later analyze and learn about how often these events can occur. And of course, we mainly want to prevent deterioration rather than treat them. When they are happening, that's bad. So if we closely monitor our babies, then maybe we can prevent of having any deterioration. We have to be able to promptly respond to any change, and we have to have always trained personnel in-house to be able to approach this deterioration. How can we detect the deterioration? Well, in the intermediate care room should never be left unattended. And I know this is a big challenge sometimes when they are missing, we have shortage of personnel, but this can be, has to be a must in a hospital where we want to treat babies with CPAP. And we have to be able to recognize when this is a real deterioration or it's an artifact on our monitor. Why it is so important to diagnose and treat the deterioration? Because hypoxic events, short or long, cause brain damage. And also, if we have a pneumothorax, then we have even further compromise to the brain circulation, and the damage to the brain will be even worse. So baby is deteriorating on the CPAP. What do? We get suddenly to the baby because we are there in the room. We can hear the alarm going on. And we check the baby if the baby is breathing. We check all the connections, if they are all secure, and we'll go through them, recapitulate everything that we have to look at. We have to check the nasal prongs that are in place. We have to empty the stomach from food or air. Listen to the lung to see the air entry on both sides, and know at all times where is a personnel that you need to call if something really goes wrong. Practicing to listen with a stethoscope would be something that each nurse in the neonatal room can practice and learn. It's not a big deal to hear lung air entrance and to compare the two sides where they are equal or any compromise to the air entry. So the deterioration can be caused by a failure of the equipment or something related to the patient herself or itself. So let's go through the issues related to the patient and the issue related to the equipment. So about the patient, first we look at the possibility of an obstruction in the nose, either by a wrong positioned prongs or some secretions in the nose, or something that is blocking the nares. And the signs would be that, of course, we see secretions. We see that the breathing is paradoxical, so the chest and the abdomen are going in different directions. And usually, when it's an issue of secretions, the deterioration is intermittent. It's not, sometimes it's intermittent. So for this, you have to have a suction at bedside and approach with appropriately suctioning the nose. Of course, pneumothorax, this would be a poor air, as this is when the pleura ruptures and the air enters the space between the chest wall and the lung, compressing the lung and causing inappropriate air entrance to that side. So this can be detected. This is an abrupt event, usually, not always. It will be an asymmetry of the chest, sometimes visible to the eyes. And it can be a sudden bradycardia, drop in the heart rate. We can use a technique of transillumination. I didn't bring a picture of it, but it can be used especially in small babies. And if the room is dark enough, we can use transillumination to see this chest, actually this part being illuminated differently from the normal side. So when we diagnose, the CPAP, the pneumothorax, then we have to take the baby off the CPAP and do the needle aspiration to treat it. Of course, the preventive method would be to always use a PEEP, the minimum pressure necessary for good ventilation and oxygenation, and we'll talk about it later. Aspiration, this is related to food. You will see some milk in the mouth of the baby. The baby is in distress, is tachycardic, and again, the air entry will be poor on both sides or on one side. And for approaching this problem, we have to look at the NG tube. It's in place to aspirate the residua or air from the stomach, and then see later on if we do some physiotherapy to release the obstruction of the food that entered eventually the lungs. Of course, to prevent this, we have to carefully look always as the NG tube is positioned well, secured well, and the baby is positioned in a correct position in order to prevent. Prone position would be the best, and we'll have later on some advices about positioning. Gastric distension is also a reason for deterioration. Usually air can, the sign will be the increase in abdominal circumference, and this will, the air which entered the stomach presses the diaphragm and actually is influencing the normal breathing. So we have to check that, again, there is not too much air in the stomach. Again, the positioning, maybe small and frequent feedings in order to prevent a further extension. And of course, if you need to stop feeding and put an IV fluid, this will be sometimes a way to approach and let the baby rest and decompress the abdomen. Sometimes the deterioration is due to a clinical worsening of the baseline disease that the baby has. So if it's an infection or atelectasis or spasm of the airways, of course can be, and it would be needing a clinical approach according to the diagnosis. Nasal trauma is also something that we always check, because when the nares are engorged and painful and even hurt, then this can cause deterioration in the ventilation of the baby. So we really have to work on preventing this by using appropriate prongs, and also to do the securing of the tubing in a way that would not hurt the nares. And also the humidification which goes through the CPAP machine is also something that prevents further damage to the nasal septum. The equipment that I hope everybody is familiar with, and we'll have next month session again reviewing all the issues related to the equipment itself. But the failure, the deterioration might be something technical due to something that is in these tubes, either disconnected, either kink, either not enough water, either the air is not somebody went by the machine and the flow was changed and the CPAP was changed, so something technical. So let's go again a little bit slower, approach the technical problem. All times it should be somebody in-house that knows how to look at the machine and make sure that knows all the technical issues, check the bubbling, and have always the checklist at the bedside. And you remember the checklist of the bubble CPAP, which is attached to the machine, and go through it one by one. So I know that we chart in the, we'll see in a moment some examples. We do chart that the checklist was done, but make sure, like in the airplane, we all know what the instructions are to prepare how to prepare for emergency situation in the airplane, but they go on a routine one by one, reading and repeating all the checklist that is necessary. So when you do the checklist, go through each line and make sure that everything is in place on a regular basis. So this is like preventing the deterioration from technical problem. And this is the CPAP machine. So when you have some problem, always when you have a problem, you suspect there is some problem with the tubes, see the bubbling in this bottle of the water, see the level of the water that is correct, see the CPAP that somebody didn't change the level of CPAP that you decided for the baby, and always do the checklist. The prong should be in place, that it's in the nose of the baby, and in the position that should be it, and the mouth is not very open, and that's what we need in order to make sure that technically the CPAP and all the parameters that we decided for the baby is what we decided, and it is going on. So it's very often that you can find something technical and fix it in a few minutes and treat the deterioration of the baby. So when there is no bubbles in the little bottle, you have to check again all the connections, and there is no occluded tube. Sometimes there will be some, the tubes can be hurt by a hole or something, and you have to change them in order to make sure that there is no leak. And you can increase the CPAP to see whether the bubbling is also increasing. This means that that the connections are okay. This is a checklist which I remind you, and this is a picture actually what you have on each of the machine. So you assess the nares for blockage and consider suction, verify the nozzle prong size and placement, check of the water in the CPAP tubing, empty the water if present. In the tubing itself, sometimes there is water and this has to be emptied. You have to check that the O2 and the airflow rates are set correctly. Check and regulate the CPAP tubing if connected and fixed in place. Verify the CPAP levels and check for bubbling the CPAP chamber. This is a checklist that is checked regularly on a baby on CPAP every 2 hours to prevent deterioration. And if deterioration happens, then you recheck to make sure that all this is working. You have to, if a baby deteriorates on CPAP, you also have to consider other causes of deterioration, such as seizure or a foreign body, or issues related to cardiac problems, like a very low systolic pressure, a weak pulse, or a problem related to the gastrointestinal system, such as necrotizing enterocolitis, or maybe a congenital anomaly, such as diaphragmatic hernia. This will be other causes of deterioration based on a different pathology or and not related to the equipment, as we said. This is an algorithm which I am not sure that you are using it on a daily basis, and I will encourage, I will send it to Rita and Ashura that it's to go through it, because it's a very useful and simple algorithm to decision making on babies on CPAP. And for the specific of this specific talk, you can see here that there is also, it starts by telling us what are the indications for a CPAP, and then how to start the CPAP. And then you have the green part, which says, what do we do if the baby improves? And we'll talk about this side when we are talking about the next lecture on the weaning. And if it's worsening, this is what actually I was trying to go through with you on this part of the algorithm, which says worsening of the clinical state as recorded by an increased down score, a higher oxygen need, and a rapid increase in the oxygen requirement. This is that wing of the algorithm. So whenever we have a worsening of the situation with a baby, we act like this. We check, we do the safety checklist, as we said, and you have it on the machine itself. And you have to go the next step to rule out pneumothorax by listening to the chest of the baby. And if you do hear differences in the air entry, you will act upon treating pneumothorax by what we said before. I'm going to repeat it in a minute. If there is no pneumothorax, then you increase the pressure by 1 or 2 centimeters of water. And remember that you can increase with up to 10 centimeters of water in order to reach better saturation in a baby. If the RAM cannula is considered inappropriate and you have other cannulas like the Hudson, you might consider changing to this. Some hospitals would have the Hudson prongs, but most of the hospitals use the ones that we are using in our unit. And if this is not helping, then you go and start the ambu bagging. If the baby improves, then you go back to the other green part of this algorithm. So again, I come back to the point that checklist of all the issues related to technical issues of CPAP should be done at the beginning of the approach to the baby. So if you have pneumothorax, we have to stop the CPAP, observe the baby, auscultate, and then treat as we said. If there is no pneumothorax, then we increase the oxygen. The baby deteriorated, so we increase the oxygen concentration. We can increase the CPAP level up to 10, and we can consider switching the interface if this is an option, and then go to handbag if we have no other choice but ambu bagging and resuscitating the baby in this condition. The use of caffeine, of course, is always possible, especially if your clinical observation shows apnea, and especially in the preterm babies, this is an excellent treatment to prevent desaturations in a premature baby due to the apneas. So to summarize, complications on the CPAP are rare. We have to focus on prevention by monitoring respiratory score and safety checklists. And if monitored closely, the patients usually are safe, and we can actually put the baby back to the course of good improvement if we act promptly and we prevent the hypoxia from this acute event. I have a few examples. If anybody has a question up to now, I can stop for a second for some questions. If not, then we can continue to observe a few charts, which I took a photo and with the help of Benil, and some charts which yesterday Ashura sent me, and discuss some real cases that actually you have in your unit every day on babies on the CPAP. So any question to this point? Questions? No, somebody asked if we have a video of the needle aspiration treating pneumothorax. We don't. We might be able to prepare some. We don't have anything for that. Any questions? Okay, so let me go.
I'm saying that it's very easy to find videos in the internet of how to do a needle aspiration. I don't know if we are able to show it online, because probably not everybody has a good connection. But okay. I will try to find one.
Okay, so let me go back to see some of the charts. Just a minute. How do I get rid of this? I want to get rid of this. Excuse me. No. Okay.
Agi, do you want to answer Rebecca?
Sorry?
Rebecca is asking about nasal trauma. Do you want to say a few more words? Because I think that Rita or Ashura had very nice pictures of nasal trauma in the last session.
On one of my next talks, I have some pictures, and then we have to discuss. It is absolutely very important. You see in this page, it says check also the nares. Each time, if you check them and make sure that there is not pressure, it's not strong enough, and the size is appropriate. It's a very, very nursing skill. At the beginning, when we had CPAP in our setup, we had a lot of nasal trauma, and with good distancing from the septum and using the appropriate size of the prongs, it's probably, and of course the head position also, if you check, you look at the baby's face and make sure it's not pressing. If the prong will be in a specific position for hours and hours and hours, it's going to cause a pressure sore, and it's going to be unreversible damage to the septum. If you change and you look at it and you move it a little and you do very gentle suctioning, probably you can prevent this kind of damage. So let me see here what happened to this baby, or what was done. I have this page and I'm just taking a look to this page and I'm telling myself a story. The story says that this is a term baby, probably 3 kilo, 185 grams, and it's the day of admission. So the respiratory distress score was 6, and the baby was put on CPAP, 80% oxygen. Okay, the baby deteriorated to 69 saturation. And if I take a look, this is a deterioration. What can we do at this specific point in order to improve saturation? Any suggestions? Anybody hears me? Anybody from nurses who has been there? When we do this charting and we write down these numbers, this can be only, maybe it's in a few seconds, the baby came back and saturated properly. It doesn't look so, because in the next 3 hours or maybe more, up to the morning, the baby had lower than desired saturation. Did we use the CPAP appropriately and gave a level high enough in order to try and increase the saturation? Probably some changes could have been done, such as increasing the CPAP or changing to 100% oxygen. So it's still the Diamedica can give 95% oxygen by switching the airflow to the maximum and stopping the mixture of the 2 liters of air. Opa, I think the page changed. So the other issue might be that this baby is not having a respiratory condition, although I can see that it's breathing very fast, which usually in a baby with a cardiac problem would be different. Like the respiratory rate would be normal and the saturation is not increasing. But in order to make a diagnosis of a cardiac problem, we have to have a different approach to rule out a cardiac problem. I can talk about this, but I don't want to mix all the information. Here in this situation, a baby with a high respiratory rate, diagnosed probably of some kind of lung problem, we can actually take some action upon this low saturation. What happened to this baby next day? Next day, the CPAP the baby still was saturating lowish, and only in the 8 o'clock in the afternoon, we first see, or maybe in the late in the night, we can see actually the baby had 99 saturation just by itself. The CPAP was not changed, 5, which is a minimum. Oxygen concentration was the same. So this is 2 things that I can comment on this page. One is that we can add some more respiratory support, either by increasing the CPAP or by giving 100% oxygen. And I also can say almost for sure that this baby does not have cardiac problem, as the saturation is like a hyperoxic test. The baby can saturate to 99, which cyanotic heart disease cannot be a diagnosis in such a case. Okay, what else we can see, and we'll discuss it in another talk. This baby was not feeding at this point at all. The glucose level was checked very nicely, intermittently, very well. So we know that the glucose was good. And we can see that the checklist was done, and actually the CPAP was working fine. And this is what we learned from this baby. This is another baby. Again, this is a small baby. 2 kilo. I think it's, I looked in the chart, it was a 34-week baby. And again, the CPAP level was 5 all the night, with a saturation which were good, borderline, but good. And the next day, the baby was saturating on the same CPAP level. Actually, the CPAP level was increased to 7, as you can see here, and the saturation went up to 99 all the time. And we'll discuss the weaning. This is very high saturation that we have to act upon it. And when you record a saturation of 99, then you have to do some weaning at this point. Oxygen concentration here was 80%, like 2 and 8, airflow of 2 and oxygen of 8, and was not changed all the night, all the day, despite the fact that the baby was saturating very well. And we'll practice later on how to do the weaning steps in such a baby to make sure that it's not hyperoxic. Okay. Okay, there were some cases which Ashura sent me. I will leave them to after the talk on the weaning babies on CPAP, and we'll see what were the decision-making points that this baby raised for Ashura's care in this baby, and we'll discuss it on the practical level. So, okay, so this was a few of the very nice charting that I could read through it and tell myself a story, and gives us an opportunity to further explore how can we react to any changes on the saturation of a baby on a CPAP. So questions, please. Rita, Ashura, nurses, what were your problems, challenges during taking care of the baby that you can raise for us to consider that maybe we don't know? Anybody? The algorithm that I showed you, are we using it in our units for now, or Rita, Ashura? We cannot hear anybody.
Agi, can you comment a little bit more about the baby that was desaturating? Do we have any, I don't know if you were able to look at all the file, or if Rita, I don't know if it's a baby from Santres or from Kumasi South, but it would be interesting to know what happened to this baby and why he desaturated. If you managed to figure out what was his problem, his basic problem, because we just showed that he had desaturations and the ways that we could improve his condition, but any idea of what happened to this baby?
What I saw on this baby is that the baby was diagnosed as asphyxia. Is this, let me see, which one is it? this one. So if this is a baby with asphyxia, and we'll talk about it in the weaning session, one of the things that I always need to ask myself, actually, why do I give CPAP to this baby? What is the working diagnosis? If the working diagnosis is pneumonia or meconium aspiration, then you would say maybe this baby had a lung condition. Maybe it was a pulmonary hypertension also involved, which often happens in asphyxiated babies or meconium aspiration clinical states. And then actually the low saturation is a vascular problem rather than a ventilatory problem. This depends on what we hear on auscultating on the baby's lung. I didn't find any documentation of meconium stained amniotic fluid, so I couldn't say whether this is a meconium aspiration. It said asphyxia. The other thing that has to be considered, if we measure the saturation on the left hand, it can be a post-ductal saturation rather than a pre-ductal saturation. I know that the instructions are to put the saturation monitor on the right hand. So if this is all right hand measurements, then it's pre-ductal. So the possibility that this baby had some kind of vasculatory compromise, acidosis, metabolic acidosis, or whatever happens in hypoxia, in an asphyxia, that all the vasculature constricts, maybe this was a problem, because as soon as it opened up, the baby could saturate at 99 and wean from the ventilator later on. Maybe this is what happened. I'm not sure.
You did not find a form telling what was the reason that the baby was connected to CPAP?
Sorry?
I mean, we have a form
Yes.
in the units that states why the baby was connected to CPAP, if it was because of respiratory distress or because of hypoxia or apneic spells. And I wonder if in this case it was noted. Now, I don't know which case it was, but it would have been helpful to have this. And also it's important to ask ourselves every time, why did we connect the baby to the CPAP? Was that a good indication? Maybe we're not helping the baby.
Okay, as I said, we'll give a little bit of emphasis on this, especially this when we discuss the weaning process, that we have to first answer ourselves the questions: why do we actually give this baby CPAP, and what do we expect to be the clinical course of this disease? And we'll talk about it in the next lecture. I would appreciate practical questions. I try to keep this talk as practical as possible.
You can even write down questions in the chat and we will answer them.
Definitely. Okay. So there is...
hello?
Yes?
My name is Dr. Buedu. I'm not a pediatrician. I joined, I'm a manager of myself hospital, but I'm picking some few good things from the presentation, and I think I like it. I want to know, so in the neonates, I'm an obstetrician. When we have the baby, you're saying that checking the saturation should always be done on the left finger and not and on the right finger and not the left finger. Is that the message I'm getting here?
Dr. Boadu, it's the right hand.
Could you please repeat your question?
I'm asking, I think I got the impression that sometimes there might be some kind of differences. Checking the saturation of the neonates using the right fingers as against the left fingers. That's where I need a clarification.
Okay, so there is a condition in the newborn which is called persistent fatal circulation, and it means that the blood is going, instead of going to the lung, it's going through the patent ductus arteriosus to the aorta, and it is blood which is not oxygenated by the lung. This condition is very common in babies with meconium aspiration and babies with asphyxia. When we do the saturation on the right hand, this is actually the saturation that the brain will see, because it is before it's mixed by the ductus arteriosus on the left side of the body and the left hand. And when we give oxygen, we actually want to know how much oxygen is needed in order to have a good oxygen to the brain. That's why we usually need to measure the saturation on the right hand of the baby. Left hand can be low, and then you will increase the oxygen, and actually it's not needed. Okay, so the issue is thinking about the possibility of pulmonary hypertension. This is a condition in term babies, very seldom in preterm babies, and it is in babies with asphyxia and meconium aspiration.
Okay.
Agi,
thank you.
First, thank you very much. I think that Dr. Boadu, it would be nice to see you, because practically Kumasi South is your hospital and you're the medical superintendent, and we are very pleased that you joined us. It's not, we are really, it's nice to see that this workshop, that you know about it and you are here with us. So we really, we really appreciate it. So thank you for being here.
You are welcome, sir.
Oh, okay. I am sure that Rita and Ashura, you will take this presentation, go again with through it with the nurses, and practice some of the issues raised by it, and see whether it is clear, and write us questions, and we will be more than happy to answer any questions.
Okay.